Hi, my name is Teresa Brannon. I am the Manager for Training and Technical Assistance at the National Center for Health and the Aging, a project in North American management. I am honored to have with me three distinguished guests that will be talking about how to recruit, retain, and motivate culturally competent staff to support senior patients. What makes a great health center? Well, it's definitely the staff. And Mr. Fuentes, Mr. Vincent, and Ms. Williams will discuss the importance in hiring, retaining, and motivating staff members to support the day-to-day operations of your community health center. Mr. Fuentes, Mr. Vincent, and Ms. Williams will focus on developing and implementing culturally competency training programs and innovative approaches to identify and retain culturally competent staff for your health center. Today, Mr. Fuentes is a Houston native and is the founder and chief executive officer of Houston Area Community Services. Mr. Fuentes founded the organization in 1998 as an AIDS service organization. HACS has grown with the needs of the greater Houston community that it serves based on its missions to provide the highest quality of care to the people of greater Houston metro area regardless of their ability to pay. HACS is a local 501c3 nonprofit health and human services organization that offers medical services, behavioral health, outreach, pharmacy, and housing-related services. As CEO, Mr. Fuentes is the primary force behind the development and ongoing sustainability of the organization. He has transformed the organization from a single-focused social service agency to a multi-service organization with multiple revenue-generating and sustainable business lines. Prior to founding Houston Area Community Services, Mr. Fuentes served as the Social Services Manager at the University of Texas Health Science Center's Houston Recovery Campus and Program Manager at the Department of Veterans Affairs in Houston, Texas. He currently serves as a member of numerous boards, including the Ryan White Planning Council, Community Planning Group, Coalition for the Homeless, Harris County Healthcare Alliance, Partnerships for Health, National Association Healthcare Centers, National Center for Public and Permanent Care, Greater Houston Health Connect, and the Greater Heights Chamber of Commerce. Mr. Fuentes has also served as a consultant to the Centers for Disease Control and Prevention, CDC, Health Resource Services Administration, Substance Abuse Mental Health Services Administration, as well as other national and grassroots agencies across the nation. He holds an undergraduate degree from the University of Houston and a master's degree in business administration from the Mays Business School at Texas A&M University. Ms. Karen Williams is the Associate Vice President at West End Medical Centers and has an extensive experience in directing diverse healthcare program operations such as primary care to public housing residents, primary care and behavioral health integration, school-based clinics, mobile health services, and many other at-risk initiatives. Directing special healthcare programs includes strategic planning, research, legislative, and regulatory brief preparation. Ms. Williams' current position as Associate Vice President is at the Federally Qualified Health Center 330E, 330I for the last 20 years at West End Medical Centers, and has encompassed the development and operation of full-service primary care services along with ancillary supportive services. Ms. Williams has successfully opened 9 primary care satellites, all giving voice and healthcare accessibility to at-risk populations. These efforts included marketing plans, environmental needs assessment, cost projections, and an integration of project teams both internal and external. Having effectively managed standalone primary care operations, fiscal budgets, clinical and administrative challenges has led to best practice models. Ms. Williams had the ability to work with a broad range of staff personnel, external environment constituents, federal agencies, and legislative policy, and has been essential in program development. Her academic training was received from the University of North Carolina at Chapel Hill with a BS and Mercer University with an MS Healthcare Training and Skill Development, and has been continued through numerous professional accreditation institutions. She has worked on numerous position papers, presentations, and healthcare proposals in development. David Vincent is a senior consultant with the National Center for Health in Public Housing and the National Center for Health and the Aging. Mr. Vincent is currently the Deputy Executive Director with the DOOR. In his current capacity, he is responsible for direction and leadership of a continuum of services targeted at the social, mental, and personal development of some of New York City's most vulnerable adolescents. Additionally, Mr. Vincent is responsible for the agency's program expansion efforts in enhancing the organization's ability to integrate, deliver, and measure its services. Prior to joining the DOOR, Mr. Vincent was the Associate Executive Director of Callan Lord Community Health Center in New York City. In this capacity, he was responsible for the development, implementation, oversight of population and health condition-specific services, including HIV services, women's health services, mental health, oral health services, adolescent health services, and health education. Mr. Vincent is responsible for adherence to government funding requirements and regulatory. He has served as Family Health Centers of San Diego's Assistant Director, Special Populations, and Mobile Medical Services. He was administratively responsible for several federal, state, local, and private foundation grants and contracts, including the daily operations of the San Diego Health Care for the Homeless Project and the Public Housing Primary Care Project. Mr. Vincent received his master's degree in social work from Boston University.
Hi, thank you so much, Teresa. It's a pleasure to be with everybody today. I'm hoping you can all hear me. I would first like to thank the National Center for Health and the Aging for hosting today's webinar. And thank you to Astral Webb, Dr. Astral Webb, for inviting me to participate in this call. Additionally, I'd love to thank HRSA for sponsoring this call as well. So today's webinar is on how to recruit, retain, and motivate culturally competent staff to support our senior patients. Let me see, having a tiny bit of technical difficulty. There we go. Just some basic demographic information on our senior population. This really shouldn't be a surprise to most people. In 1990, there were about 6 million seniors, Asian Americans, Native Americans, Hispanic, African Americans, who were over the age of 60 years old. And that number, 6 million, really just relates to the communities of color. So that number jumped up to 7 million in 2000, and that really represents a significant growth. The growth for Hispanics alone was 45%, which represents about 2.5 million individuals, 2.5 million seniors. And among Native Americans, that grew over 24% in that same decade. Where are seniors in our community health center? According to our most recent UDS, or UDS back in 2011, community health centers saw over 20 million patients, and of that number, 1.4 million were seniors over the age of 65 years old. That represents about 7% of the average census of CHCs. When we look at the special populations, the 330H, G, and I programs, seniors are represented in each of those programs. They're most greatly represented in the PHPC, which is the health and public housing. They represent almost 5%, little less in migrant, and even less in our healthcare for the homeless program. One can assume that there are many factors that contribute to those numbers. I'm sure the stability of housing, public housing, for our senior residents probably reflects why seniors are seen more in that project. So as we look to cultural competence, and this is a definition from the National Association of Social Workers. As you noted from the first slide, I am a social worker, so there are a few references here according to social work. Cultural competence refers to the process by which individuals and systems can respond respectively and effectively to people of all cultures, language, classes, race, and ethnic backgrounds. And it really is a full encompassing terminology. When we look at cultural competence, researchers really have found that cultural competence is one of which that operates on a continuum. So if you look down at the very bottom, you see cultural destructiveness. And that really is when someone disregards cross-cultural awareness and knowledge and behavior. It's a complete denial, one might say. That moves on to cultural incapacity, where someone doesn't accept that there are multiple perspectives of cultural competence or of the various cultures. Moving on to cultural blindness. Cultural blindness disregards the diverse religious cultural practice when scheduling hours of operation, services, really not taking culture into consideration when operating their health center. As we move on, cultural pre-competence is when someone exhibits visual representation of all ethnicities, genders, age in their operation of their health center, moving toward cultural competence. So most agencies and most individuals hopefully sort of fall between these two levels. Cultural competence is when agencies provide regular staff training on cultural competence and service provision. And then really what we're hoping for is complete cultural proficiency. And that's when services are provided in languages that most represent the populations that are served. Then we, when you're thinking about determining cultural competence and really identifying what it looks like to identify a culturally competent staff member, you really have to determine what your culture is. You really have to take a step back and say, what's happening here in our health center? Are we meeting the needs of all of our population? Are we only seeing Latinos? What about our African American patients? Are we effectively reaching our senior population? Looking at your local census, are you really seeing the fair amount of seniors that you should be seeing? And taking a step back and doing an assessment on what you might not be doing well. Where are your barriers to care? Where are the gaps in your services? Are those gaps administrative? Are you providing culturally representative staff? Do you have only young staff at the front desk that some of our senior patients might be intimidated about? Are programs appropriately designed to best meet the needs of our senior patient? And then also looking at, when you're looking for new staff members, it's prioritizing what level of importance. Do they have the clinical skills that you need? Do they best represent what's more important? Language, race, ethnicity, gender. You always, when I'm hiring a provider, you always look for someone who speaks Spanish, who's a person of color, who's an older woman, and you're looking for that perfect composition, and really figuring out how you're going to go target that person. Or are you looking for a member of the community? Is it important to have a member of public housing, for instance, if you're developing a health education program specifically targeted to reaching senior citizens? Do you want to choose a member from that public housing community? And is that important for you, or is it less important? And trying to figure out what level of importance that has for you. When you're thinking about identifying that staff person, and this is not news to anyone who's done anything in hiring, it's really, online hiring really has tended to be the way that health centers are going. Indeed, Craigslist, working with your local PCA or PCO, placing ads in nonprofit organizations and listservs, but specifically when you're interested in reaching providers who have experience or a desire to work with seniors, it's really about taking the opportunity to look at some of the gerontological associations. There are several of them, and they are based by discipline. There's some for social workers, there's some for nursing, there's some for nurse practitioners, some for medical providers, and really taking a few seconds to look at whether that might be an opportunity for you. Also, understanding that there is a digital divide, so understanding that you can't just solely rely on electronic postings for positions. For instance, if in fact you are looking for a health educator to work in your public housing project and you want them to be a senior because this project targets seniors, you have to appreciate that many seniors do not have access to computers, and posting on Indeed or Craigslist may not have the same effect when you're reaching specific populations, and taking all that into consideration when you're posting for positions. Additionally, one of the greatest opportunities for many individuals in hiring culturally competent staff is really referrals from staff and colleagues. Staff have a tremendous knowledge about the community and who's coming in who might best fit the agency. They're on those front lines every single day and really taking an opportunity to use your staff appropriately for that. Additionally, networking is a tremendous opportunity for identifying appropriate culturally competent staff members in working with seniors. Looking at the local Department of Aging, some of the senior centers, those provide wonderful opportunities for staff. Additionally, when you're working with some of the special populations, networking with your local housing authority, understanding that there are several community resident organizations that might provide opportunities, whether it's a Head Start group, whether it's a resident council, all of those provide wonderful opportunities for identifying potential staff. As we look at what's important in identifying quality employees, they really have to have core traits. You know, you can't underestimate the value of having a provider or a staff person who has compassion and caring and authenticity, especially when working with seniors. Those are key traits that employees and staff need to have. They do also need to have an understanding of the struggles that many seniors have. Many seniors struggle to find food, and they have limited finances and restricted finances. Their age may have caused some physical limitations. They may have challenges climbing stairs or just basic mobility stuff. Also understanding that there are language barriers that face many of our senior citizens, and lack of transportation. You know, I'm in New York City. Public transportation is all over the place. However, public transportation isn't really all over the place. We have some communities that have very, very limited transportation, and many seniors live in them, and you wonder how they're getting to and from their appointments. Also, finding a quality employee is one of the key things is finding someone who's dedicated to the work and to the agency mission. We do know that individuals who are committed to the mission tend to be happy and tend to stay. We also want to find someone who has the appropriate gerontological experience and skills, whether it's social work, whether it's nursing, whether it's a medical provider, making sure that they have the competencies needed in order to work most effectively with this population. Additionally, you're looking for someone who has excellent communication skills, someone who is patient and understands that there are nuances in working with the senior population that to most effectively communicate with them. Understanding that, you know, standing up while they're sitting may not be the most effective way. They may have some issues with their hearing and many different issues that always need to be taken into consideration. And of course, finding employees that are punctual and energetic and taking initiative, and then of course making sure that you find employees that are going to fit within your agency. You always want to bring in someone that is going to be nice to work with. So when we think about having a little shift of here, when we look at employees' expectations of what's important, this is from an employee standpoint, and this is an interesting survey that was done a few years ago. Employees are most interested in having interesting work, followed by appreciation for the work they've done, being in on things in the agency, job security, good pay, I mean, you can read this. So this is a top 10 list of what employees think is important from their perspective. And this is actually an interesting thing. This is actually a study that was done in the healthcare industry. So this is pretty applicable to us. So when we look at the same study, looking at managers and what managers think are important, this was their manager's response. So when they thought about their employees, they actually thought good pay was #1, followed by job security. So it's really interesting just to see the disparity between the two worlds. There are some of them are right on line, help with personal problems with a 9 for each of them. But what is more troubling, not only is the good pay from 1 from a manager's perspective to a 5 on an employee's perspective, was the difference between, from an employee perspective of being appreciated for work that they've done and feeling being in on things. Those 2 items were number 2 and 3 from an employee perspective. However, were 8 and 10 from a manager's perspective. So managers are really missing the boat on this. And as a result, they're losing lots and lots of competent staff that are valuable to their health center. Some facts and myths about staff retention, wage really isn't the reason that people are leaving. They're leaving because of their relationship with their supervisor. So individuals, you know, it's a common thing in sort of management 101 is when someone leaves, they're firing their supervisor. They're just not happy. They also did a study looking at the incentive programs. And this study was not a health center study. It's based on the for-profit world. When they were looking at retention and the value of incentives, giving an incentive to an employee actually only lasted, the value of it only lasted about 30 days. So granted, this isn't for health centers and the healthcare industry, but you know, when you're thinking about incentives and cash bonus, remember in some industries, the value of it is very little. So using those incentive options, one must be judicious. Employees, the same study looked at employees who take on more responsibility. And employees are more apt to take on more responsibility when they like their supervisor, when they feel that they have a supportive supervisor. So those are all really key to that relationship. Additionally, employees feel loyalty is such a powerful, powerful incentive. And agencies really need to remember that and remember that that loyalty is a two-way street, both from an employee standpoint as well as from an agency standpoint. And as we all know, employee satisfaction is directly related to staff turnover. So when staff aren't happy, we see staff leaving, unfortunately. And no health center can afford to lose staff. So why? Because the cost of recruiting are crazy expensive. The training of staff, there was a study a few years ago that was done talking about the expenses. It takes, you know, it can take 9 months to a year to really recoup some of those costs related to staff turnover, especially in some of those key providers. So if you lose a gerontologist, moves on from your site, trying to find someone up and bringing them up to speed and having them carry a full panel again, really is very, very costly. Keeping staff energized, obviously we shared a little while ago, helps reduce the turnover. The impact always is positive. And another sort of key point is about negative impact. As we all know, when we've managed staff, that when you have a staff that is not happy, they are toxic to the environment. And so transitioning the staff out who aren't happy is something that one needs to do so expeditiously oftentimes, because you don't want to have them in an environment where they bring other people down and contaminate your your pool, so to speak. An interesting study, this study was done on incentives, and these are really just non-monetary incentives. And this is what staff note that they did not receive. Personal thanks, 58% say that they did not receive personal thanks from their supervisor. 76% said that they had never received a written thanks from their supervisor. 78% said they never received a promotion based on their performance. 81%, and I sort of find this very troubling, note that they had not received public praise for any of the work that they had done. And then 92% said that they had not participated in a meeting that was sort of one of those staff building, morale building experiences. These are all opportunities that health centers have that don't cost a lot of money, that just take a few extra seconds in order to let an employee know that they are valued. Because the goal here is about retaining really great staff. And a personal note, a public praise at an all-staff meeting, that goes a long way, an awful long way. And here's another sort of social worky thing, you know, a social worker always throws in Maslow somewhere in here. So as we're looking at employees' motivation, and one of the key foundational pieces is making sure that their physical environment is important. Employees are really interested in knowing that they have a desk, an office, and pens. That's one of the key foundational issues for employee motivation, followed by security, making sure that they have a steady paycheck, and then followed by having a positive relationship with their peers at work, followed by job recognition and having meaningful work, which is an interesting thing to sort of see all of those Maslowian hierarchical, I'm sorry, I'm having a word problem, needs fleshed out with motivation. When we think about motivation and staff support, the problem for many employees is about job satisfaction. And as a result, the primary goal of a supervisor is really just about improving morale and job satisfaction. Every part of their job should be about what can I do to help you meet your goals that you need. You know, one of the common things I say to my direct reports is, you know, my job is to support you, to help you do your job. And I think people like that. People like to know that they have someone that's there to help them meet the needs. What we do know is that there are many, many job-related stresses that impact our employees. We have the need to increase productivity. We have the need to see more patients if another provider calls in sick. We have a need to go to another clinic location because they're, you know, whatever needs, you know what I mean? And that all seriously impacts the morale and adds additional stress to some of our employees. And what we have found is that worker frustration unfortunately becomes staff burnout. And being proactive and addressing some of those issues will help retain some of our staff. When we think about discussing multiculturalism in supervision, it's really about having a clear understanding of what the expectations are and really helping the employee understand that there is a relationship of trust and empathy, and all of that just reduces fear and helps them feel that they are being supported. The supervisor does need to work with their staff person on supporting them in their exploration and development of cultural competence, in working with the senior population, providing them with additional opportunities. So, for instance, in addition to seeing patients, perhaps they attend a monthly meeting at a senior center. Something, you know, appreciating that not all of the work with the senior population and all the competence is going to be built in that health center, and that there is a need for external opportunities, and that really has benefits both from an agency standpoint as well as from a supervisee standpoint. Communication is key in helping retain excellent staff. Communication needs to be clear and regular and consistent, and all of those wonderful, wonderful buzzwords. Letting individuals know what their job expectations are and having them be very, very clear. There's some manager 101 feedback about how to give feedback to staff members and making it constructive. Some organizations believe that the ratio should be about a 3-to-1 ratio, making there 3 positive feedbacks or 4 positive feedbacks to 1 negative feedback. Because if you hit someone too hard with that negative feedback, that you run the risk of them not receiving that feedback very well, and as a result, them not being happy and seeking alternative employment. And one of the key things about giving feedback is really making sure it's timely. And as soon as that event occurs, making sure that that feedback is provided. Also making sure that that feedback is provided publicly is a great, great opportunity. Celebrating successes. These are all wonderful opportunities to help keep staff motivated. Everyone loves positive feedback. Everyone loves to know where they stand and that they are valued in the health center, and that success really should be celebrated, whether it's big or small. So I am happy to, I believe, turn it over to Joe Fuentes. Joe, are you with us?
I am, David. Thanks so much. And I have an affinity for social workers because we hire so many of y'all, so thank you. Again, my name is Joe Fuentes, and I am the CEO with Houston Area Community Services. And I kind of want to provide an overview of our infrastructure because that's one of the things that David referred to. And then at the end of the presentation, I'm going to hand it over to Karen, who I'm really excited to hear from because she runs a really great program. So let me give some history about our organization. Our corporate life began in 1998 as an AIDS service organization. And at the time, the epidemic in the city of Houston was really moving from a white gay male demographic to communities of color. And that is how our organization formed, was in a response to serving people of color, in particular African Americans and Hispanics, with services. And I do joke about this a little, but there are some things where you would think that make common sense to an organization or just to an individual. If I'm a monolingual Spanish-speaking person, that does not mean if you yell at me in English, I'm going to understand that English any better. So that's just an example of some of the things that we encountered in our history. But we actually grew from there in terms of looking at quality. In 2005, we became accredited by Joint Commission for Ambulatory Care and Behavioral Health. And as many of y'all work in health centers as well as hospitals and other institutions, you know those policies and procedures can be rather sterile. And I'll talk about that a little bit later as well. And so we really wanted to put our mark in terms of making sure that our infrastructure, including our policies and procedures, really embedded our grassroots beginnings, but also made sure that our policies and procedures were fluid enough to address different cultures in terms of either whether it's a racial ethnicity, in terms of Hispanic, African American, other populations who we serve, the LGBT community, people who are homeless, people who have chronic conditions, and making sure that that whole infrastructure could accommodate pretty much everybody. And I have a saying that I say to my staff, we can't be all things to all people, but we certainly try to. So I just want to throw that out there. But within that, we also in 2009 became an FQHC, which expanded our entire organization to provide a full aspect of healthcare. And while we always talk about health centers, I'm also going to throw another dynamic in here, which also includes housing. We're also a provider of, some of y'all may be familiar with the continuum of care grants, which are homeless grants that serve people who are individuals and families who are homeless. And within that, one of our newer projects actually reflects housing in terms of people, older adults, which I consider myself in training because I'm 46. So I'm just gearing up to that. So, so one of the things that we do, what I want to do is talk about our services and how we've done that. And so for strategies for developing, implementing an environment that supports cultural diversity, there's some things that, that when you look at certain things, these are the things that we tend to look at in an organization as a whole. Individual rights and responsibilities, provision of care, treatment. David referred to some of this in terms of having gerontologists available. Medication management, of course, if we're working with older adults, and people who have chronic conditions, sometimes that is very important in that everybody's involved in that, in the care of that individual or even the family as well. Infection prevention and control. Performance improvement, we can talk about PCHM and Joint Commission. I'll be happy to talk about that, but it's not my favorite topic. Leadership, environment of care, management of human resources, which David also alluded to, information management, and provision of care. And if y'all go to the next screen, thanks. So this is kind of the cultural competence framework that we've agreed as an organization, as well as the board, and including our consumer advisory boards, really looked at. And there's more of these. These came from the Office of Minority Health. And so we kind of selected these 4 standards to be at the bare minimum, what we should do. And these also are in line with NCQA and Joint Commission. And then you can read these for yourself, but I'll just go over them really briefly. Staff provides language assistance services. For us, that also meant to make sure that we had the ability to communicate with our populations who demonstrated a need for other languages. And that includes people who speak Spanish and a small percentage of people who speak Vietnamese within our organization. Now, unfortunately, right now we don't have staff to accommodate that, but we use the AT&T language line, as well as using the multicultural center studies, which they provide translators for us, and medical translators, not just, which I often get very upset with other providers when they say, "Well, we pulled a person in that's not in that profession." It just drives me crazy. That's not a pet peeve of mine. Standard 5, the agency provides all materials, verbal instructions, and written notices in the patient's preferred language. And if we're working with older adults too, when we talk about signage and wayfinding within an organization, for people that may have sight impairment, or just like me, as I get older, they told me I had 40itis, and so that just means I'm getting older and can't see, we really want to make sure that the signage in our building is really at an appropriate font size where we can see and maneuver around our facility, which is 33,000 square feet, so it's a big facility, and making sure that our patients can actually be independent and move around, and then if they need assistance, we provide that. Standard 6, HACS verifies language competency, which is written and verbal, and that's written in our policy procedures in terms of even during pre-employment. All of our staff members go through a process in our HR process where not only are they providing writing samples, we also sit them down with the hiring manager and or other staff members to speak that language. And so that is one of the things that we've often found where people say they'll put on their on the employment form, "I'm bilingual," but it's more than, burrito and, all those kinds of things. So, and I joke about it, but honestly, sometimes it really does happen. And then Standard 7 is Joint Commission and NCQA requirements that patient-related, and I'll talk about this, and post signage in the language of the commonly encountered and represented groups in all of our service area sites. So for us, that's really important, again, as we have a big site, and I'm making sure that it's the same kind of language that you utilize across multiple sites. And that's also important because if one of our patients is going into our main campus to one of our satellite locations, we want to make sure that that language is still commonly used between both sites. David, next slide, please, if you don't mind. And this is what I'm referring to, and this is how we kind of diagrammed it. Back in 2001, we actually received 2 grants from SAMHSA, and they were both targeted capacity expansion grants. One for mental health, one for mental health, and one for substance abuse treatment services. And this is kind of the diagram that we utilize to look internally into making sure that our policies and procedures are actually meeting the needs not only of what we need to do for all of our accreditations, licenses, grantors, funders, site visits, and all that good stuff, but also for our staff as well as our patients. And you could talk. One of the top ones, if you look at the organizational management, is just really looking at what is defined in those things in terms of organizational values. And so that's one of the things that we really try to look at. Governance is also the other piece. Your board needs to be really involved in this process, and I can't stress that enough. For our organization, we make sure, pretty much every health center has the 51% consumer. And at any given point in time, that can fluctuate in terms of race and ethnicity. And we tend not to beat ourselves up over that too much, only because we have no control if people are coming in or out of our system, or we have people that move or transition off the board. So we do look at that and try to make sure that we're reflective, not only in the board, but also with the staff of the communities who we serve. Planning also refers to all the other plans and implementation. And so a lot of times that can mean something as simple as, when do you start your clinic and for what type of panel? And the example that I give in terms of just cultural competence and even in terms of learning for personal growth for me was when we initially started, we have a gender variant transgender clinic. as one of our programs. And for me, I had no idea how to address that community. And so we enlisted people from the community. We had a consumer advisory board, and we were also able to recruit and hire 2 staff members who were transgender individuals. And the one thing that we often look at, again, is that what we look at ourselves in terms of saying, okay, well, this is how I do it, or this is how the agency's always operated. And you kind of have to disengage from that and kind of be fluid and really open to suggestion and not take anything as a personal affront. And so the example I give about that is when we had our first patient come in, they were scheduled at 9 o'clock, and they also relied on public transportation within our community. And if you're from Houston, or if you know anything about Houston or just Texas, we're one big urban sprawl. So anywhere it could be 30 minutes. But if you're relying on public transportation, that can break down, it could be late. And so for having a transgender individual come to our clinic, who could also be senior, by the way, and we do have senior transgender individuals, the issue became that person had to really make a concerted effort to come in and get ready 3 hours before that appointment, and also risk the fact that they could experience ridicule, abuse, right, wrong, or indifferent from people just accessing public transportation. So we laxed up on that a lot for that particular panel, and I don't mean that in disrespect, but we have to we're looking at tailoring and individualizing an entire program around the community. And I think that's where we have to go with it sometimes. And so for us, and again, for me personally, it was a really interesting learning experience, but also really lend ourselves to looking at all the populations that we serve and trying to do that. So that's just one example. Monitoring evaluation, that could be anything from having culturally competent staff. One of our policies and procedures, or at least one of the mandates that we have, is that each staff member, regardless if they're administration or not, or a direct service provider, have to have at least 8 hours of cultural competence training. And that can include from a race or ethnicity, excuse me, I should be remembering all this stuff now, race or ethnicity. But it also can include things in terms of populations we serve, including the homeless, the substance abuse community, LGBT, people living with HIV and AIDS, and other aspects of the people who we serve. Oral and communication, again, we talked about this, staff development, piece of that. The organizational infrastructure, we really do utilize a lot of consumer advisory boards, especially when we lack that expertise ourselves as a staff and as a board, or a board. And so I really encourage that. And some of y'all may use resident councils as well to get that feedback. And then, of course, services, screening, assessment, care planning, and treatment. All that embodies this patient-centered medical home and an integrated approach to care. Next slide. Can I run on next slide? Right. So I'm going to but that's really the aspects on our issue. And for us, again, those key critical components really have to be looked at. You can also do this with committees. We have a leadership committee, compliance and performance improvement committee, credentialing, pharmacy and therapeutics, ethics, safety, and consumer advisory boards. Each of those have integration in terms of really providing a holistic approach to care, but it also has to do with the fact that making sure that all the needs of our clients, regardless of race, ethnicity, and ability to pay, or age, that all of that needs to be considered when we're implementing a project and reviewing that project, and even doing PDCA cycles to improve those projects. So I'm going to hand it over to Karen. I know I went really fast, but I speak really fast, so I apologize, and I hope there's some questions if y'all have any, and I'll be able to answer them. So I'm really excited to hand it over to Karen.
Hi, good afternoon. Thank you so much, David and Joe. You have already set the stage pretty well for recruitment and exactly how we work together. Tell you a little bit about West End Medical Centers. We're a 330 community health center, federally qualified health center, 330E, as well as a public housing primary care, 330I. We're an urban FQHC, also with satellites out in various county areas that make up Metro Atlanta. We have been a community health center now for 38 years with providing care to public housing residents for the last 22 years, and in that is included providing primary care to residents, seniors that reside in public housing communities, as well as at our other satellites in other areas where we reach out to seniors. We have had a long history of collaborations and partnerships which have sustained us to help meet the goals and requirements that are needed for us to provide comprehensive primary care services throughout the life cycles, that including our seniors, adults, pediatric population, through a sundry of means, that being, as I mentioned, public housing with senior residences, school-based models, also mobile health units where we take our mobile unit, which is both primary care and oral health, to various senior locations, schools, and any other organizations so that there is an access point to care. One of the strategies mainly when we're looking at, in addition to some of those that have already been addressed, is giving an overview of the expectations and meeting the populations that we serve. What are those needs? So when we're recruiting and looking for someone to fill the role as either provider or support staff for the populations that we're serving, and with our seniors, we're looking for a very clear understanding of the potential candidate, exactly who we are as a community health center, and what the expectation is for delivering that care. So if you look at the next slide, this is just a verbiage from Healthy People 2020. It's something that's used initially on for any new employee that we're bringing on board, to make the picture very, very clear that there's a very diverse population and that we are trying to reach with a broad range. And there are many attributes that go into meeting the healthcare need of an individual. We also look at the zip code area, which may be a real interest to from a potential candidate that we're looking for to serve a particular population. And then, of course, the health disparate conditions. If it's, I think Joe mentioned HIV, if it's a community that is heavily concentrated, or if it's a site that's heavily concentrated with a particular health disparate or a chronic disease, then we want to make sure that the staff that we bring on board are fully aware, fully trained, and have the wherewithal to meet that need and the expectation of the agency. And then, of course, we're looking at access to care. That access to care, as I mentioned, may be on site in a senior high-rise building, as we have, or it may be on mobile services. However the mean is, access to care and making sure that the continuum and continuity of care is something that's valued. So after we talk about the most vulnerable populations, through traditional means, I think David's already very clearly talked about in recruiting we use social media for recruiting, online, word of mouth, trade organizations when we're looking for staff to fill the need in a particular population. And so then if we move on to the next chart here, we want to put all the pieces together that have been talked about. How do we recruit? How do we retain? And how do we motivate? But ultimately that has to fit, putting all the pieces together, fit with the overall organizational structure. So then if we talk about what our mission is for the agency, and that mission being that we provide the highest quality of comprehensive care services that is culturally and linguistically appropriate, as well as accessible and affordable, focusing on prevention and early diagnosis, then we're to make sure that we do that in a sundry of ways in the recruiting process. Once the staff is hired, that there are several trainings to go on that staff participate in that talks about the mission. As we know that the mission is also part of our board of directors that have signed off on as to what our agency is to be about. So training at the onset of every new employee, orientation, be it from human resource, be it from supervisor, be it from even our advisory committees that make up either both through patient as well as peer groups from other staff. But the mission is really the forefront to ensure that this is a good fit and putting all the pieces together. Then when we look at the vision, for us here at West End Medical Center, our core vision, initial vision, is to make sure that there's an educated community, meaning that there's a total access to primary care that results in healthier lifestyles and measurable improvements in the health status indicators. That vision, as it's handed down through our corporate organization as well as through our board, but also through our funding source, which is HRSA, to make sure that we have benchmarks that we are meeting. And we can only meet that through the staff that we have that we are have gone through training either culturally competent, and I think, Joe, you mentioned earlier, not necessarily just language, as in our community we have several languages here in our agency, that being French, Spanish, Laotian, Russian, and then several dialects of sub-Saharan African French-speaking populations. So it's not just the language, but it's also the culture as well. So then if we talk about in one particular senior high-rise where we provide care, there's a large Russian speaking population. But not only is it the language of the staff that we use, but it's also being able to address those senior needs. If it's mobility, that transportation is needed, so that there is a culture exposure of the populations that we're serving that our staff are able to meet, be it through social work with support services and referrals, or it being the behavioral health counselor that may need to unearth some other issues, some family issues, so that we're addressing family dynamics as well as the individual dynamics. Many times with our seniors, there may be a sense of isolation. So we try to reach out to the family as much as possible to deal with if someone has become homebound of recent and what all that means, but still tying into and making sure our staff adhere to what the mission and vision is, and that vision being to have an educated community. And that community includes the family, it includes the staff that work in that particular housing community, and any other agency that may be coming into play in that community. Then when we look at our values, and again, we go through the normal human resource screening, training on values when we're looking at putting all these pieces together. So once we've assessed and ascertained whether or not a staff person meets all the basic criteria, that may be with credentialing, that may be licensing, all of those standard protocols, there's still a sense of ongoing training that all of our staff, and we've got staff that are pretty long in longevity and tenure of employment here. I think our average is somewhere around 15 to 19 years of our staff retention. And when we look at values, I think, David, you gave a really interesting slide of how the perception of employer versus employee is, be it praise, be it thanks. All of those are values of the agency. And so we sat down and kind of came together with a team in our agency to look at those various things. And so we've come away with a few things that ranked high on the list for staff retention, and that being one, flexibility. Many staff value flexibility in work time. And so when we kind of match that with the values of the agency, we're looking at whether or not we have staff that prefer morning, that may want to come in from 7:30 to 3:30, or someone that wants to work evening hours, say from 1 to 9. So we take all those things in consideration, flexibility of work time. We also take in consideration that some may want to do a four-day work week, so get 40 hours in one day. All of those things work towards meeting the value of our agency, and also those things that are valued by a staff personnel. Then we look at strategies of how to do that. It may be that one location is closer to some employee to where they live as opposed to another. So how can we work with that, with those strategies? Is it possible? And if not, is one of the other departments more? Is it mobile, where you meet with at one location and join the mobile team to go to various locations during the week? So a number of incentive ways so that there's value added for the employee as well as value added for the agency. We also look at, as a basis, training. Training is very important. There are mandatory trainings that the agency requires for staff to have, those being very germane to the expertise of that employee, say CMEs for our physician, medical staff, whether it's training, if it's our intake with billing or intake, whatever is germane to that particular career path and career growth of that employee, we make sure that there is an agency very clear, definitive line as to what the expectation is there. But then also, if there are other areas that staff may find that it puts them in something new or adds another dimension to their career with our agency. It may be a training in exercise. If I know one of our providers was very interested in getting more information on exercise care. So then that was added on. We searched for some classes. We brought in staff to our agency that provided we call brown bag lunches to talk about exercise. So there are a number of key points that may be a little bit out of the box or out of those lines that you may think cross over into another area. But if it's interesting enough to one staff person, that means that it's probably interesting to another. So we try to host a series of topics that are discussed that many staff can avail themselves. And you'll find that when it's thought that those questions are heard by an organization and are valued enough that there's an action that's taken, so that there's a series of training sessions in a particular area, it becomes more comfortable for the staff person, not only as an individual but also as an organization. Give you one example. We have had even with our seniors, we did a priority list for the seniors had to identify or rank what they thought were most pressing issues to them, health issues to them. Now there was another list that the healthcare team had come up with, but it was matched with the list of the seniors themselves on a survey that had provided, and the list differed. It somewhat, not by much, but by the perhaps prioritizing. But some of the things that our healthcare team had not even thought about, STD information, depression counseling, socialization clubs, were some at the top of the list of the patients that we're providing in some of the senior high-rises. So then we had to have our healthcare team come together, and if there was an area that was outside of their scope, we had to bring in certified or professional staff in a particular area area to assist the healthcare team in delivering the services that were needed. So then it all goes right back to the first slide with the Healthy People 2020, looking at all of those aspects, not just the pathology that we're seeing from the healthcare team that's being presented, but looking at all of the aspects, the psychosocial issues of the population that we're serving. So then if you've ticked off all those boxes of matching the mission, vision, values, and strategies, then ultimately you're looking at sustainability. I think we all have come away with that a happy workforce is a productive workforce, and a productive workforce is a healthier patient base or community. So then if we're looking at all of those values, those things that we value, then we're much more able to provide the quality, the compassion, the respect, the ethics, and even attending to the diversity of the populations that we're serving. And then it gives an initiative, so it encourages a culture by rewarding and continuous learning on the front line in decision making and teamwork, and not just the monetary that we're able to provide to pay our staff, but clearly concerned and involved about the training, concerned about the growth of the individual, and thus it translates to the population that we're serving. And as an organization, the sustainability of our bottom line is ultimately, you often hear without a margin there's no mission. So it goes right back around to the organizational mission as well as meeting the mission of those individual patients that we're providing care to. And I echo what has said before, and if there are any questions, I don't know, David, now if we're going to open up for questions, or how would you like to move forward?
I believe we are.
Oh, sorry, David. Thank you, Joe Fuentes, Karen Williams, and David Vincent for an excellent presentation on how to recruit, retain, and motivate culturally competent staff. I do have a few questions, and for people that need to go, I understand, but we are a little bit over time, but I have some questions for the group and individual questions as well. So here's one. What should you do when staff repeatedly leave after only working at the agency for a short period of time? Anyone can answer this.
This is Joe. We actually just had that recently. We actually went through NAC and used one of their providers to recruit the CFO. That person stayed for 2 weeks and left. So you talk about what David had talked about in terms of resources and really, doing that. I think it has a lot to do with, like I stated, if you kind of even used our framework, for example, the one that I presented in terms of organizational management and resources, it really has to do with, the way I see it, at least as the CEO of our organization, that it's so diverse in terms of our workforce. There's personalized schedules. There are certain demands of the organization, and it goes back to the whole value, what is really important to the organization. And so if it's patient care, no matter what even our individual needs, we put that first. And so for us, it's making sure that the proper supports and resources are available to that individual. And it's looking at not only the job description, but it's also looking in terms of the environment that you're providing for that particular employee. And for us, it can range from anything from making sure that we're providing computer access where the screens are larger for people who may not be able to see well, making sure that there's other audio-visual type assistance for that individual. Sometimes it can be as easy as just providing a PTO policy for people of different cultures and races in terms of, let's say, taking time off for whether it's a religious ceremony or for other types of things in the community that they need to attend. And so it really is quite dynamic in terms of looking at, your overall policy. But I always start with the job description and the policy and the infrastructure. And that's just my personal take on it. And of course, we get HR involved, the hiring manager. But from my perspective as a CEO for the organization, I really want to make sure that we've allocated and really reviewed every type of resource to make sure that's available to that individual.
Okay, thank you, Mr. Fuentes. The next question, or Karen or David, do you have anything to add?
No, I don't have anything to add. That's exactly the same steps that we have taken, and it does happen. sometimes more frequently than you would like, because you've put so much effort in that employee, and then there's a short turnaround time of the value that you've put into recruiting that employee.
Okay, thank you. Next question. When hiring older adults, what steps should you take to recruit them without making them feel disadvantaged, inadequate, or unqualified to meet the needs of the job? Basically what they're asking is how to make someone, or an old person, not feel old.
Karen, will you take that and talk about your how you work with your public housing sites with your seniors? You guys do a great job.
Sure.
Yeah.
Sure. It's part of being a part of the community. As I mentioned, there are several populations that we provide care, and for seniors, that is a population that may be most familiar, most comfortable, or senior may choose to go in one of the other areas. But we work with our housing authority, with the resident services, so that we become entrenched and knowledgeable about upcoming opportunities, either with our agency or our collaborative partners agency. So then I guess perhaps I would answer it best because we have advisory committees as well as focus groups on seniors. I'd probably answer it best by really valuing our seniors. That's a patient base that we value. We don't see any shortcomings as far as tasks that a job may entail for a senior that may be applying for a particular position. It may be in our outreach department, which is essential to our organization, which is the liaison to the community, or if it's, for example, in our front desk with intake, where we've had seniors that currently still work. It's valuing the population as a whole, our patient base as well as our staff, so that any barriers such as, I think as you said earlier, Tricia, too old is not too old, because that's a thriving population that we're providing care to.
Excellent. Great answer there, Karen. I actually have another question for you, Karen. What is the actual cultural competence training model that prepares staff for the job at your health center?
Through our HR department, each staff initially has questions that are asked, survey, and then that's talked about with one of our HR reps. And so then once a person is hired, we have a cultural competency training module for all of our staff. It may include role play. It may include guest speakers to come in and talk about what is culturally competent. Oftentimes, I think I said earlier, and I think Joe also echoed, cultural competency is not just speaking the language of a community, and it's not just being of the same ethnicity of a population that you're serving, but there are awareness and of culture of a community that is gone through each quarter. All staff go through a training of cultural competency. As I mentioned, that may be through briefing of a document that's provided. It may be through a lecture series. But, you know, often I think our staff have found that role play, being actually involved, are some really take-home lessons regarding culture competency, because it's something that's visual and really something tangible to think about, how we look at another person that's of a different culture and how we relate. I think, Joe, you mentioned shouting to someone in English doesn't reduce the barrier there. So things like that are included in our training.
Right, great, thank you. This is the next question to anyone. Do you get supplemental funding to have continuous training for staff?
We do not. We include that in our package with staff. It's part of when we hire a staff, part of the fringe that we look at education training. So all of that's rolled in so that we can have speakers come in, so that we can, if someone has a course that they'd like to go attend, all of that's included.
Right. And this is Joe. We have it in two different ways. We actually embed that in a lot of our grants, and so the funding source sometimes requires the type of training, and so we do adhere to that. But internally, as an agency as a whole, what we have is the 8 hours of required training, and then based on anything that the supervisor and their supervisee comes up with in the development plan, we have to make sure that we have the resources to make sure that they can adhere to that plan. So for us, it's also putting aside dollars to make sure that we, as an agency, do agency-wide training, make sure that occurs, but also for the individual development plans for each of those, each staff member. And same thing with me and the board. The board actually puts money aside for me to also have cultural competence training, as well as other mandated training that's required by any grant or source.
Okay. So I think this is the last question. Is train the trainer methodology used at your center? And this is to Joe or Karen.
It is at ours. It's one method.
And in ours, it is also train the trainer. We kind of see that as cross-training also, so that there's a training and awareness. We do it on a number of fronts, both internal and external. Train the trainer. We may have peer training where we have our outreach staff train in health education assessments, being aware of health issues in the community. So yeah, we do have both internal and external train the trainer.
And I just want to touch on one thing that Karen said too that we do as well, and I think it's really important too, is the observation piece of it, especially during the training pieces, because having somebody report back on your performance that's observing you, whether it's a supervisor, we kind of took it a step further, and even at consumers, they provide great feedback during your interaction with other patients or other consumers. And so that was one process of that as well.
Excellent. Okay, well, that's it for the questions. I'd like to thank everyone for participating in today's webinar.